From Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi everybody, welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we discuss inpatient rehabilitation and specifically cardiac rehab and updated findings on sternal precautions. Our guest today is Dr. Alexander Bajorek, the Medical Director of Inpatient Rehab at Sarasota Memorial. Dr. Bajorek, thank you so much for joining us.
The pleasure is absolutely mine.
Let's begin by addressing the different levels of rehab. Can you just start with the basics? What are they?
Absolutely. So I like to think of rehab as a continuum. So there are different levels based on what your needs are. Anything can pretty much happen medically to you and affect your functional status. Your functional status being, how do you get about in life? How do you get dressed? How do you use a restroom? How do you bathe? How do you walk? And if any of that is affected by anything from a motor vehicle accident to heart failure, or to a CABG, a surgery by a cardiothoracic surgeon, we'll talk about, completely can upend your life. You can become dependent on others, and there's a road to recovery and there's a pathway to that. That can be as easy as just going home, getting home health services. So you have a therapist and a nurse come to the house, make sure that you're doing okay in your home environment. Or it could be outpatient therapy where you have someone, usually a loved one, drive you to the outpatient therapy office 2 to 3 times per week, 4 to 6 weeks, try to get stronger. But if it's really debilitating and there's a lot of medical complications, sometimes you go to an inpatient setting. The most intensive inpatient setting is intensive or inpatient rehabilitation, and that's where I work, and that's where I'm the medical director. There's also a skilled nursing facility, which is a little bit less intensive, but still has oversight by a physician and nursing and therapists. And it just really depends on how much intensity you need and what your medical complications are. And that can really determine, in addition to how you're doing functionally, where you end up in terms of rehab.
So let's focus on that inpatient rehab, since that's what you do. What are the criteria to qualify for inpatient rehab?
Simultaneously, there are very little and a lot of criteria depending on the situation. And so that sounds vague, but I'll try to explain. The number one thing is, can you tolerate intensive therapy? So if we are going to get you up and moving for 3 hours a day with a physical therapist, generally, think of it hips down, mobility, occupational therapist, hips up, getting dressed, using the restroom, self-care, speech-language pathologist for swallowing function and for your thinking, so cognition, as well as speech. If you can tolerate 3 hours of therapy a day for 15 hours on average a week, then you can participate in an intensive rehab setting. Sometimes at the beginning of your stay, you may not be able to do that, but then as you improve, you can. And so it's incumbent upon me and anyone who's evaluating the case to see is it projecting that you'll be able to tolerate that therapy. You also have to have medical necessity, meaning you have to have a physician see you at least 3 times a week. There has to be a medical need for that. So if there's really not a lot going on medically, probably don't need that intensive of a program unless it's a specific diagnosis that's compliant. We have to get 60% of our patients have to fall under a certain criteria. And most of ours do, and we're always over that percentage. That would be things like brain injury. Let's say you get in a motor vehicle accident or spinal cord injury, amputations, strokes, hip fractures, heart failure, and all the way down to COPD exacerbation. And so there are different criteria that I have to look at. In addition to that, including, can you be expected to get back into the community after us? The idea of coming to inpatient rehab is that we can get you back into the community after us. And if you're not expected to be there until maybe 2 or 3 months from now, maybe a lower level, more prolonged rehabilitation stay at a skilled nursing facility would be more appropriate.
What are the obstacles patients face to get inpatient rehab?
The number one, I think, that we're seeing is really just ignorance of the option. So you get admitted into a hospital in the area. If you're here at SMH, you're at Venice, they know about us, and they know to refer to us, especially if it's a recognizable diagnosis that they typically refer. Some hospitals in the community, really we're serving at this point a lot of the Gulf Coast, a lot of the Tampa Bay area. Some hospitals aren't as aware of the need or really even what inpatient rehabilitation is. So sometimes the first obstacle to address is just make your case manager aware that there is an inpatient rehabilitation facility in town, within driving distance, within transport distance. We take from all over Florida and out of state. And then you can send the referral. Another big barrier is if you're sending that referral and it's going through an insurance company, then you have to wait for insurance authorization. That may not go through. And often in those times, just having an advocate from your doctor on the inpatient side to do a peer-to-peer or even a family member can sometimes make a difference in overturning that denial and getting the patient in. So I would say just increasing awareness, which is kind of the point of this interview, is to let everyone know that it exists. It is really beneficial for patient functional outcomes and medical outcomes. But also there are some sticking points with red tape, with insurance and the compliance measures that we were talking about.
What sets the Rehab Pavilion at Sarasota Memorial apart from other rehab programs?
At this point in my career, I've worked at 4 rehabilitation facilities, either in training or working. And this is the best facility that I've worked at. Comparable would be maybe in Boston, Spalding and Harvard. But a lot of the materials, the technology, the staffing, and the technical expertise that we have here is comparable, if not better. We have a new building, started in 2016, but the program was running for decades before that. The biggest thing I would say that separates us from other inpatient rehab facilities in the area of Sarasota is that we're connected to SMH. Massive difference. If you're at another facility and something happens medically, you'll have to oftentimes, if they can't handle it, be sent to an ambulance and go to the emergency room at another hospital. With us, we're attached to SMH, so we can get consults, we can get acute medical management, procedures, images, most likely happening almost immediately to stabilize and keep you in rehab so you're not going back and forth between facilities. Now, of course, there's always some percentage that have to go back in-house. We're consistently lower than the nation percentage-wise for acute send-outs by at least 50%, which is excellent. All the docs that are referring you from Sarasota Memorial to inpatient rehab have the ability to see you in inpatient rehab. In other facilities, they may not have privileges there. They may not be able to keep an eye on you. So you get a back surgery, there's a worry about your incision. Your surgeon can literally walk over across the hallway, see you, take a look at it, order imaging if needed. We'll be talking about cardiothoracic surgery patients. They can come over. They actually send their team and regularly follow their patients to make sure that they're doing well with us. So we have a lot of support from all of our colleagues on the acute side, which really helps us optimize the discharge process and get patients back to their lives quicker, safer, with lower rates of acute send-out, lower rates of 30-day readmission.
On the next episode of HealthCasts, we're speaking with one of your colleagues, Dr. Ryan Hafner, about neuro rehab specifically, and learning about the needs of patients for spasticity management after a serious neurologic event. Is there a specific rehabilitation for patients who have those cardiac events you referenced?
Dr. Hafner is excellent. We're excited to have him on board from a neuro and a spasticity management. So I hope everyone will watch his podcast as well and come see him in an outpatient clinic. So in terms of cardiac rehab, the biggest issue, again, really comes down to almost ignorance again. Not a lot of patients realize that you can go through cardiac rehab. The World Health Organization shows that it's being underutilized massively on a worldwide scale, but also nationally. It's not typically thought of benefiting from inpatient rehab, but we consistently take a whole stretch and different variety of cardiac rehabilitation patients, from patients who are just simply in heart failure and just need to work on their conditioning, to full, sternotomy patients who have undergone a CABG procedure after suffering a heart attack. So we see the whole gamut, and the the usefulness is clear when you see them in the inpatient side. Medically, we're managing them and making sure that we can continue to titrate their medications so that their fluid status, their blood pressure, their heart rate, everything is optimizing before they leave. Simultaneously, we're working on their pulmonary and cardiac conditioning, so heart and lung conditioning, so we can get them stronger physiologically, so they can walk longer distances, so that they can take care of themselves more independently.
What makes cardiac rehab different than other types of rehab, and what are the unique needs of this patient group?
Cardiac rehab is interesting because we're putting them through what essentially equates to moderate aerobic exercise activity. And these are patients who have just had either heart surgery or heart failure. So there's always a worry. Am I going to be able to tolerate intensive rehabilitation? And you can. And the earlier you get it, generally the better you do. And we're finding that consistently across research studies. So the biggest concern, of course, that we're looking at from our standpoint is making sure that we don't reach certain thresholds for, let's say, heart rate and blood pressure, and then we'll adjust and tailor individually that cardiac program to that patient. So there are different phases of cardiac rehabilitation. We're essentially the first and second phase, and then as you go further out in time, second, third phase is an outpatient and then beyond. And we have outpatient cardiac rehabilitation programs as well after patients are far enough out from their surgery.
If someone has an open heart procedure, like you spoke about before, or really any chest procedure, it's especially important to focus on something called sternal precautions. Can you explain what those are?
I'm going to explain what they were, and then we're going to talk about what they are now. And the terminology precautions in and of itself is even changing. So traditionally, sternal precautions consisted of basically restricting all movement or lifting. So you couldn't reach overhead, move your elbow above a certain level above your shoulder. You were not supposed to lift more than 10 pounds of any weight. And what they were finding is that from hospital to hospital, but really state to state and across the nation, huge inconsistencies between physicians and what they were prescribing and how restrictive and what specifics they were giving them and how long it was going to last. And that really created a lot of confusion for patients and found that they didn't get functionally improved as quick as they probably could, and that they didn't go home as quickly as they probably could. So they ended up in skilled nursing facilities or at inpatient rehab facilities instead of going home. So that paradigm is changing, and that's what we'll talk about, the specifics of it and how we've changed and updated our practices here at SMH to reflect the change in the research that's been going on nationally.
So that leads me to my next question, because as you referenced, the discussion surrounding sternal precautions has changed. What are those updates?
Keep your move in the tube. So that's the name of the new set of sternal precautions that's coming out. Originally from Baylor in Texas, they did a lot of research where they had patients who had sternotomies, and they would measure the force that the sternum would take just coughing or sneezing. And this was in upwards, what would you guess, how many pounds of force from a sneeze or a cough?
Oh, I couldn't even guess.
It's upwards sometimes to 80 or 100 pounds of force. So then they would compare that with the activities that they were restricting with the traditional sternal precautions, obviously much less force. So where's the disconnect there? So they have cardiac pillows, different devices to prevent that force being subjected directly to the sternum. So they did more research. They had some patients actually go out and push a lawnmower around their yard, and they found that their sternum was completely intact. The forces were similar. They weren't seeing the biggest concern that surgeons were worried about, which is dehiscence when the sternum comes apart or gets infection, any kind of complication along the incision. So they developed something that was based off biomechanical models. And they found that really force comes down to a lever arm. So the further out you are, the more force there is. So they came up with this program and then tested it fastidiously for over 10 years, looking at, is this safe? and they found that not only was it safe without increased incidence of infection or dehiscence coming apart, they also noticed that it led patients to going home sooner and becoming functionally independent sooner. The concept being you have this tube over your body and you're trying to do all your activity within that tube if it's bearing weight. So if a patient gets like a hip fracture, the traditional precautions are weight bearing as tolerated. It's somewhat similar of an idea. If you're keeping your arms within the tube and you're lifting a certain amount of weight, as long as you're within the tube and you do it without pain, then you can progress slowly with your activity. But non-weight bearing activity no longer has the same restrictions as long as it's, again, without pain. So there's a lot more education and specifics to it. So please don't take just this information for the full background for these updated precautions. But so far we've implemented it here at SMH and we're seeing some positive preliminary findings.
We actually, your team produced a Keep Your Move in the Tube video, which I recommend everyone go to youtube.com/SMHCS and they can see the Keep Your Move in the Tube video to learn a little bit more about those precautions. What else has SMH done regarding these updates?
So we've done an entire house-wide, from acute to inpatient to outpatient to our SNF to every SMH entity, update of these precautions educationally with all staff, with all patients. It's been a massive undertaking that's taken several years. It's been headed by Julie Ennis and Mariah Maddox, an acute therapist, and then the overhead director of the acute therapy team. So these are the therapists who are going into the acute side to evaluate patients and see if they're candidates for rehab or potentially going home. And so after we initiated this education session, came up with all the program, they've started collecting data, preliminary data, for I guess probably about half a year at this point. And they're already showing that patients are going home sooner and more likely to go home as opposed to a SNF. So leading to less hospitalization, hopefully less readmission, and of course, whenever you're in the hospital, you can get complications, so potentially lowering rates of complications, although we're still looking at that data.
Why is it so important for your team to collect that data, see that data, and make adjustments as needed?
It's just part and parcel of being in a healthcare environment. It really should be data-driven. Are you leading to increasing risk? Are you leading to increasing rates of infection or dehiscence? Those have to be number one in our mind, and that's always at the forefront for all of our therapists and particularly the surgeons. But is it making any difference? Why update a precaution set or why update a policy or a paradigm shift if it's not going to change actual outcomes? It's sometimes difficult to measure those outcomes, and some of them are easier to determine. And if you're seeing a positive trajectory, then you can make further adjustments. So we had our initial rollout, and basically on a quarterly basis, they're continually making adjustments and updates to make sure that not only does it reflect the nationwide up-to-date research, but also fits our individual specifics of our facility and all the connections that we have across the community.
Can you provide any of the or any examples of what you've seen improve?
Absolutely, in terms of actual patient stories. So I've had the opportunity of seeing just incredible patient outcomes. Probably the ones that come to mind the most are where patients really need to have functional ability in order to progress. So let's say you have an amputation previously, and you need to obviously don and doff your prosthetic. You have to use your upper arms to transfer, and then suddenly you have a heart attack, and you have a sternotomy, you have this incision, you have sternal precautions, and you can basically not push or pull or do anything within those traditional precautions. Now we have a framework to where even patients across the spectrum of functionality can start getting back to independence, which really just means getting back to your life, getting back to the community, getting back to the person that you were before the injury, before the heart attack, before the surgery. And I've seen that firsthand. I've seen, anecdotally, I haven't collected the data on this yet, but anecdotally it seems like patients are getting home quicker from us after they come to us, and they seem to be doing very well functionally.
Is there anything else you want people to know about inpatient rehab or cardiac rehab or the precautions we've spoken about today?
Number one, I just want people to be aware of the existence of inpatient rehab. I have seen incredible stories of recovery. Right now, I have a patient that comes to mind that is absolutely recovering well when everyone had written him off. It was basically saying, well, we've treated medically, there's really not much else we can do. And at this point, we're 2-3 weeks in, patient is getting close to maybe even going home. That isn't possible a lot of the times unless you get that interdisciplinary intensive rehabilitation program that we can offer and that we have right here in Sarasota. We're well ranked nationally. We're in the latest U.S. News and World Report rankings. We were ranked number 1 in Florida, 35 in the nation. So you have a nationally recognized rehabilitation facility here in your back door. Use us. Please utilize us. And if there's a question of whether you qualify, talk to your case manager, talk to your doctor. Just make them aware of our existence and come to our program so we can work together to getting you back home, back to your families, back to your loved ones, and back to the community.
Dr. Bajorek, thank you so much for being with us today.
It's my pleasure, absolutely.
And we look forward to next episode as well, talking to your colleague, Dr. Hafner, about neuro
Yes, please
rehab.
catch that. He is excellent, really good expert in his field and spasticity particularly, so we're excited to have him join the team.
Dr. Bajorek, thank you again. And as always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.